Today, I am honored to welcome Dr. Leanne Jones to the podcast. Not only is she a highly respected oncologist here in George, but also a woman who has dedicated her career to walking alongside her patients in the most vulnerable and difficult moments of their lives. Breast cancer and cancer in general is a word that brings immediate fear, confusion, and oftentimes silence. But this is why this conversation today is so important, to shed the light, because far too often diagnoses are delayed, warning signs are ignored, or women feel dismissed. Dr. Leanne, baie dankie vir jou tyd vandag. I really do appreciate it. I know it's your weekend off and now you have to talk to me.
Oh, it's such a privilege to be here, and thank you for inviting me. I think this is such an important topic. I think we're going to open a few cans of worms today, but hopefully we're going to enlighten a lot of people.
Thank you, Dr. Leanne. Dr. Leanne, tell me, before we dive into this difficult topic, who is Dr. Leanne Jones, and why? That's always the fascinating question for me, is why each doctor chosen their specialty? Why oncology?
Okay. So I think firstly, I'm a wife and a mom. Although they probably take a little bit of a backseat to the work. Oncology for me has been a calling. It's something I was led to do. I was exposed to it when I did my community service in 1999. I was one of the first years to do community service in the Eastern Cape, and I was exposed to a pediatric oncology clinic there.
Wow.
Yeah. And when I applied for a post at Grooteskier Hospital, I got accepted as a registrar, and all the doors opened for me after that. So it's definitely a calling. It's not something you just wake up one day and say, oh, I want to be an oncologist, because as you correctly said, it's quite a tough job here. But there's a lot of hope. So we have to focus on that today.
Exactly. Okay. Tell me, Leanne, so for how long have you been practicing and doing oncology specifically?
So I finished my specialization in 2004. So I've been in private practice for 21 years.
Sure.
Yeah.
Oh, so that's a long...
And a lot has changed in 21 years.
And that is what we want to talk about.
Exactly. So we'll go through the things we were excited about and the things we are excited about and how things have changed.
Exactly. Yeah. That is what we want to get into. Dr. Leanne, so let's start with our topic regarding breast cancer specifically today. What is breast cancer and cancer in general?
So any cancer starts with a cell that's gone wrong. A normal cell that has divided, and in that process of dividing, there's been a genetic change. The body hasn't recognized that change, and that cell has been given the opportunity to grow, multiply, and then become a cancer. So in general, cancer will be a growth that is uncontrolled because of its genetic instability. It's uncontrolled in the organ that it started in, and it also has the ability to grow outside of that organ. So what we call metastasize. So it can travel to other organs. And that's the thing we fear when it comes to cancer. No, so that will be for any cancer. And a cancer is classified according to the organ it started in. So if you've had breast cancer, it's always breast cancer. If it's been something that started elsewhere, it's according to the organ it started in. Yes.
Okay.
So even if it spreads to the liver, it's still breast cancer.
Okay. Oh, I didn't know that.
Yeah.
Dr. Leanne, and if we talk about, we've spoken or referred to the genetic change in that cell, lifestyle factors and genetic factors that plays a role. How do we?
So for the majority of patients, and that's 90 to 95% of patients, we can't pinpoint a single thing that's caused their cancer. It's usually multifactorial. So for most of us, it will be whether or not we follow a healthy diet. We exercise regularly. We focus on limiting our alcohol intake. And I'm going to just focus on that one a little bit, because when we were at varsity doing our undergrad, they always said, well, a woman can have 7 units of alcohol a week and a man can have 14 units of alcohol a week, and that's safe. But that's safe to prevent liver failure. That's not safe to prevent any other diseases. So the latest data is to prevent cancer, we shouldn't have more than 3 units a week. That's 3 glasses of wine, 3 beers, 3 anything, 3. Only
week.
Per week. Yeah, exactly. Exactly. So we have that problem. Yeah. Well, most of us do. Hey.
Yeah.
So anything more than 3 units per week is associated with a higher risk of cancer, not just breast cancer, cancer.
Sure.
So other factors would be smoking. With regards to lifestyle, whether you had your children late, whether you breastfed or not. Then when it comes to genetics, it's what the family history is, whether there were multiple patients or family members who had cancer. And it's not just breast cancer. Breast cancer, prostate cancer, ovarian cancer. And then there are a few that people forget about, but melanoma, stomach cancer, pancreas cancer. And all of those can point to a genetic abnormality or something you inherited from your mother or father. Can be from either. It doesn't have to be from your mom. So it can come from your father's side of the family. And we speak generally of a BRCA mutation.
Yes.
So BRCA 1 or 2. So I think most people know about Angelina Jolie, I think she brought it to the forefront. We all heard about her being diagnosed with a BRCA mutation and having bilateral mastectomies. So a BRCA mutation means that you lack a protein, the BRCA protein, that is responsible for DNA repair. So that, when we go back to what we said about the cell having a DNA damage and it being able to divide with that damage, when you have a BRCA mutation, you don't have the protein that helps your body recognize that damage and correct it.
Okay.
So your body has no way of correcting that damage, which gives you a much higher risk of cancer, specifically hereditary breast and ovarian cancer. So a patient who has a BRCA1 mutation would have a 65% risk of breast cancer by the age of 70.
Sure.
65%. A BRCA2 patient would have a 45% risk, and the average population would be about 12%. Okay.
Sure.
So that's 1 in 8 patients. So it's a very big difference in your risk of getting breast cancer. So we generally would see those patients will have, quite extensive family histories. There'll be cousins, aunts, mothers, people who've had breast cancer under the age of 45, patients with specific types of breast cancer, and we'll probably go into that a bit later. There's what we call sort of cancer families.
So for the BRCA test, when do I know I should test for that?
I think that's quite a difficult question.
Is it?
Yeah, but I think it has to be addressed. So the most important thing is you are not going to go to your GP or to a lab and say, do a BRCA test on me. What you're going to do is, if you suspect that there's something in the family because there's the strong family history, you're going to see a genetic counselor. Okay. That's where it starts. No one should have a genetic test without first seeing a genetic counselor because the test has got quite significant implications. So if you test positive, there are quite a few things that need to happen. You need to be helped with that or assisted with accepting that risk that you carry. So you have a high risk of breast cancer, ovarian cancer, it could be pancreas, numerous cancers. You need to be told what that risk is and what screening program needs to be undertaken and whether or not you need certain surgeries. So remember, I'm an oncologist, so I see the patients who already have cancer. The best is if there's someone in the family who has cancer, that person gets tested. So you have what we call an index patient, someone who already has cancer in the family. You test that person to see, has the family got a gene?
Okay.
And then you take it further. So if you, as the average person, has no family history no family history of cancer, you're not just going to go for a genetic test.
Okay.
Yeah. So it's not a routine screening test like you would go for a full blood count or a mammogram, or it's something that's going to be a specifically indicated test. So for us, we would always take a family history when we see a new patient. But then there's certain types of cancer, certain subclassifications of breast cancer, and also any patient who gets breast cancer under the age of 45, we would certainly consider genetic testing.
Okay.
It's quite an expensive test. Medical aids don't always cover it, generally. I prefer, if my patients, obviously after counseling, do a panel that gets done overseas by an in vitro lab, and they do what we call next generation sequencing. So they test 70 genes.
Sure.
It's not just BRCA1 and BRCA2.
Okay,
There are many more genes associated with breast cancer. So it's not just a simple BRCA1, BRCA2. You can get a PTEN or an ATM or a RET gene. So there are multiple genes that can be associated with breast cancer. Obviously, BRCA1 and BRCA2 are the most well-known or common ones.
And is that available? Okay, you've said now that this medical aids don't always pay for it.
So the tests that are available in South Africa are more expensive. So the overseas one is about, I think it's about $399. But because it's done outside of the borders of our country, the medical aids don't cover it.
Okay.
The South African one will vary according to the lab, anywhere between 15 and 18,000 Rand, quite a bit more. The turnaround time is longer, but it doesn't have the same, and I may speak under correction, but it's not the exact same panel, that whole 70 gene panel that we get from in vitro. And I think if there's time, but the in vitro panel, one of the nice things with that is if you test positive. So if I have a patient who tests positive, once the family has had genetic counseling, and I have to add that every time, they can then test for free under that same test. So they don't each pay that 7,000 Rand or the $399, whatever the thing is. They just need to have the counseling, and they need to get their blood to America.
Okay, so it's a blood test.
It's a blood test.
Not a swab.
No, we used to do the swab, but it's unstable. So sometimes it gets there and it's yeah. So we rather do a blood sample.
Test.
Yeah.
Okay.
Yeah.
If you're still understanding breast cancer, together with the screening and diagnosis, how powerful is early detection?
Oh, it's everything.
And that's the whole point.
Early detection is everything. So early detection will result in better prognosis, less treatment, better outcomes. So it's everything. And this is why we're doing what we're doing today.
Exactly.
Yeah.
It's everyone just knows how easy early detection can be if you
yeah.
No.
There are four real ways patients will present with breast cancer. The one will be, and this is how we want to see all our patients, would be they've been for a mammogram, they're not aware of any change in their breast, and the mammogram detects something abnormal. So what we're hoping for there would be it's a ductal carcinoma in situ, precancerous, easily treatable, no chemotherapy is needed.
Okay.
And that's what we pick up if you go for a mammogram regularly, and they're just picking up, there's a slight change in this breast. It's not even a mass. It's just calcifications that look a little bit different. So it's not about a once-off mammogram. It's about you go regularly for your mammogram, and the radiologist picks up there's a change in this mammogram.
Okay.
The other would be a doctor or you have picked up a lump in the breast. Now, typically, if you've picked up that lump, it's almost 2 centimeters. Okay. So for you to pick up the lump, it's usually 2 centimeters. For a doctor, it's usually about 1 centimeter. So it's not precancerous anymore. It's already a cancer. Right. The third way will be you've got really big breasts. You can't feel anything in your breast. and you've got a lump in your axilla, so under your arm, which means the cancer has already gone to the lymph node. Okay. And the fourth way, which is the one none of us like, would be the cancer's already spread elsewhere. Okay. And 3 and 4 we want to try and prevent. Okay.
Dr. Leanne, before we move on there, while we're on this, when do we do our first mammogram?
So mammograms are from the age of 40. Anything before that, your breasts are too dense. So a mammogram is an X-ray. It's either a 2D or a 3D X-ray of the breast. So if the breasts have a lot of active breast tissue, that X-ray cannot tell us what's happening in the middle of that breast. They're too dense. So at a younger age, you can't tell what's happening in that breast. That's why we start at 40. And also usually your risk of breast cancer has been from the age of 40, although that's changing now. Okay. A mammogram is in our area, so in Mossel Bay, George, Knysna, patients will also have an ultrasound. So that's where we use radio waves, and they would then look at the breast tissue and see that what they're seeing with that corresponds with the mammogram. So it's a twofold examination, and they need to correspond. Okay, so those are done together. It's unlikely that patients would just have a mammogram unless they're in an area where that's not available.
Okay. So from 40, if you have no family history, then is it then just your routinely?
So here's where, once again, different guidelines are different. So most medical aids will say they'll pay for a mammogram every 2 years. Okay, and that's based on, and depends on which guidelines you look at, whether you look at European or American guidelines. But you have to remember that what your medical aid's going to pay for is not necessarily what's right for you. And sometimes you need to put your hand into your pocket and you need to pay for an extra mammogram in between. A mammogram's probably going to cost what a very good hair color and cut is going to cost at a salon. So it's for your safety. You're going to go and do that. So once again, you're going to discuss that with your general practitioner or your gynecologist. There would be some patients where every 2 years will be safe. There's absolutely no family history. They have easy to examine and breast tissue that's not very dense. They're not on hormone replacement therapy, and no other risk factors. Then every 2 years should be okay. But the majority of patients, an annual, yearly mammogram should be advised.
Okay.
Yeah.
I've had one done 2 years ago, but it was also because of, I felt something, but it was, it's just dense breast tissue.
Okay.
Yeah. But what I wanted to say is I think a lot of patients also think it's so painful. It's not painful at all. Or it wasn't for me. And I have prosthesis in. So it was uncomfortable.
It's comfortable.
Well, definitely not a lekker outing for the day.
No, it is uncomfortable. It's pressure on the breasts.
Yeah.
And the newer machines maybe look, they're definitely better than what they were 10 years ago.
Is it?
But yes, it's still uncomfortable. And you know what? If you're going to find that your mammogram is uncomfortable, take 2 Panados before you go.
Yeah.
It's something you're going to do once a year. This is not something we're asking you to do every month.
Exactly.
No.
Yeah, so break them on it fast. Then the big thing is the myth that mammograms
Cause cancer.
cause cancer.
Okay. There's so many myths. So mammograms help with early detection, for sure. The amount of radiation you get from a mammogram is the same as what you would get from background radiation from the earth walking around outside for a few months. Okay, so what you're picking up walking around outside in like 3-4 months is what you're going to get from a mammogram.
Really?
Okay, it's low. These are low dose X-rays. It's not sufficient to cause cancer. So one of the the things that cause great confusion, and if I have to hear it in my practice one more time, I'm going to get a spasm in my neck. So the Swiss have said they're no longer doing screening mammograms. Okay.
Oh.
Yeah. So the study was put out with announcement
Well, okay.
by the Swiss government. They no longer, or Swiss Department of Health, they're no longer doing routine screening mammograms because it doesn't change survival. Now, you can't extrapolate that to all countries.
No.
No, we're talking about a first world country where patients regularly go to their general practitioners. They get screening for other things. They have access to first world treatments. They say it causes unnecessary investigation and unnecessary biopsies and false positives. It's not because it causes excess radiation, which is what everyone keeps saying. Oh, the Swiss have said you can't have mammograms anymore because it causes excess radiation. No, that's not why they said that. It's because they say it hasn't changed survival.
So, but the bottom line is, do your mammogram. It's not going to cause cancer.
It's not going to cause cancer. There's certain times you might need an MRI of the breast, and this has been one of the most exciting things for the garden route. Is we now have MRI breast available in both George and Mossel Bay. Up until I think it was May this year, patients had to go to Cape Town or Johannesburg for the MRIs because
Amazing.
it wasn't available here because they needed to get a specific coil for the MRI machines. It was an add-on for the radiology practices at great cost. And we now have it available routinely in both George and Mossel Bay.
Oh, amazing.
Changed practice for us. So not everyone needs an MRI, importantly.
Yes.
So it's used when you have a mammogram that shows an abnormality, but you're not sure what it is, or a patient's been diagnosed with breast cancer and you want to be 100% sure there's nothing else in that breast, or in a patient who is known with a BRCA mutation, who is not wanting to do prophylactic or preventative mastectomies, or patients with very dense breasts and you can't see anything on their mammograms. So that's when you would use an MRI of the breasts as your screening or as a test. A lot more expensive, obviously, than a mammogram. Usually funded by the medical aid if you motivate. Takes a bit longer than a mammogram.
Is it a machine that you also lie in?
You lie in face down, breast hanging down.
Yes.
And then they do an MRI, let's just say MRI, MRI of the brain.
Yes.
Just like that. And they give you contrast so they can see what the contrast uptake in the breast is. So it's about a 45-minute test. And it's usually reported by radiologists who are specialized in reporting breast MRIs because they're quite complex to report.
Okay.
Yeah.
Wow, that's amazing for us.
Fantastic.
Oh,
Change the way we practice here.
Yes, that's amazing.
Yeah.
We referred earlier to Angelina Jolie that was a
long time ago.
A long time ago, that she had her mastectomies and double.
What you do if you've got BRCA, it's both breasts.
Just explain to the listeners the difference between a mastectomy and a lumpectomy.
So a lumpectomy is where we remove just the tumor plus a ridge of or a margin of normal tissue around the tumor and leave the rest of the breast in place.
Okay.
A mastectomy is if they remove the entire breast. Okay. So when we say lumpectomy, we actually more use the term breast conserving surgery.
Wow.
So we try and keep the breast. So there are very few indications where patients have to have a mastectomy. So we really are steering away from mastectomies. So there are a few reasons why a patient would definitely need a mastectomy. The one would be if there's a genetic mutation, and then we would look at bilateral mastectomy because you have a very high risk of getting breast cancer in the other breast.
Yes.
Up to 80%. Patient choice. some patients want a mastectomy. They don't want to keep the breast. They don't want to go through that yearly issue of stressing with a mammogram, because having a diagnosis made of breast cancer is an extremely stressful process. So patient choice.
And are there often people that choose to do that? Is it?
Multiple
So it's common.
It's common. And some of them will say take both. They just can't deal with having to go through. Oh, should I say it's common? It happens. It happens.
No, I assume because you're always going to have this thing in the back of your head that next year, if I go back.
So often when patients they'll reflex say, oh, take them both. Then we'll counsel them and also just go and think about it. And often when they've just had time to process the information, they'll change their mind.
Okay.
It's just a reflex of shock at the diagnosis. And their thought is, if you take my breast, if I have a mastectomy, I'm not going to get cancer again, but that's not true. Okay. The other reason for considering a mastectomy would be if there's multifocal disease. So there's more than one cancer in the breast, and we can't save enough of the breast. If you're going to be left with a very small breast that's not cosmetically viable or appealing, then rather you do a mastectomy and a reconstruction. So then those would be the main reasons. From a cancer perspective, if there's an inflammatory cancer, which is quite an aggressive form of cancer where the cancer cells get into the lymphatics of the skin, we'd also advise a mastectomy. Then you can't keep the breast.
And when it comes to chemotherapy, radiation, targeted therapy, I assume that is also a very complicated, because that is obviously case dependent as well.
It is. So before we go into treatments, the most important thing for a breast cancer patient, so you've been diagnosed with breast cancer, you can't have just one doctor making a decision about your treatment course. There needs to be a multidisciplinary team. The multidisciplinary team needs to consist of an oncologist, a surgeon, a radiologist, a pathologist. It's important that those people speak to each other, either in a meeting or on the phone, that your case is discussed so that a treatment decision can be made. There are 6 aspects to the treatment.
Okay.
Not necessarily in the specific order. There's surgery, chemotherapy, with or without, targeted therapy, immunotherapy. Then there's endocrine therapy or hormonal treatment, and there's radiotherapy. So those are the 6 things that we use to treat breast cancer. And what you're going to get is going to depend on the size of the tumor, the personality of the tumor. I always think it sounds better in Afrikaans, die geaardheid van die tumor.
Okay, well,
What is the grade of that cancer? What does it look like under the microscope? Is it a grade 3 ugly tumor? Was it a grade 1 low proliferation index, slow growing tumor? Is it sensitive to estrogen? Is it sensitive to progesterone? Is it HER2 positive? Is it a triple negative tumor? So no 2 patients will necessarily have exactly the same tumor. And each one's treatment plan has to be individualized. So some patients will get chemotherapy first, what we call neoadjuvant treatments. And that's very important in any patient who has a HER2 positive tumor or triple negative tumor. So we know that for those patients, getting chemotherapy first prolongs survival, improves outcome. Okay, so you start with the oncologist. You don't start with a surgeon. Then there's surgery.
Okay.
Then there's possibly endocrine treatment, radiotherapy. If you have a tumor that's estrogen and progesterone receptor positive, HER2 negative, you may have surgery first. You may require chemotherapy afterwards, but you definitely get endocrine treatments.
Okay.
Whether or not you're going to need radiotherapy is going to depend on whether you keep your breast. So if patients have breast conserving surgery, they get radiotherapy or they need radiotherapy to prevent tumor recurrence in that breast. Having said that, if you decide to have a mastectomy, it doesn't mean you can necessarily get away without radiotherapy, because if you have a advanced tumor, so a large primary tumor, or there were nodes positive under the arm, you may need radiotherapy as well. But radiotherapy is a walk in the park compared to chemotherapy. I think that's the thing that every patient fears. Hey, is chemotherapy.
But chemotherapy also, all the myths around that. So what does chemotherapy do?
So there are many different types of chemotherapy, and there are also many different regimens we use in breast cancer. But in a nutshell, it will halt the division of the cancer cells. So generally, it will target cells that are growing fast, and cancer cells are growing fast. So it works on that genetic change that you've got in a cancer cell. Obviously, one's got normal cells that are also growing fast, such as your bone marrow cells, the lining of your mouth. And that's where the side effects come in, that those ones get caught in the crossfire. Having said that, things have improved so in the last 20 years. We have much better and improved anti-nausea agents, so our patients don't struggle the way they used to. Unfortunately, the hair loss is still a reality, and that's probably one of the hardest things for the woman, especially the young woman with children. The children struggle to deal with that. Yeah, because mommy looks different. Mommy looks different. Mommy doesn't have hair. But it's got a huge impact on a patient's life, and not just while they're getting it. It takes a long time for those side effects to wear off, and some side effects don't go away. You know, if that patient gets a peripheral neuropathy or the pins and needles in their hands and feet, that can be something that they've got to learn to live with. But it's that balance of your risk of the cancer coming back and the treatment that you need, and it's those always have to be looked at, and a decision needs to be made on what is required.
No, because a lot of patients or people refer to you as hulle pomp jou net vol gif. But like you said, you have to weigh the two.
The risk and the reduction, the reduction in that risk of cancer recurrence. I think at the end of the day, you know, we advise patients on what they need. It's still their choice. It's still their choice as to whether or not they have the treatment. There's some patients that I would say probably don't have a choice. A triple negative tumor, there's no choice because there's nothing else other than chemotherapy.
Especially I think, you know, when it comes to for you, I assume you make a recommendation, you tell them this is what we need to do going forward. And then, you know.
So I always say to patients, you need to earn your chemotherapy. Your case must warrant the chemotherapy.
Yeah.
Okay, so I'm not going to write it up just for the sake of writing it up. Your case must warrant it. And I'm quite conservative when it comes to that, because I know what it's going to do to your quality of life. And yes, there is hope after that, and there is a recovery, but it takes time. It takes time. But one has to remember, this is cancer. This is not an ingrown toenail or flu.
Exactly.
We're fighting cancer here.
Yeah. And with that, like you said, I didn't know the team was as big. So leave it to the people that know. And that's what always, that bugs me. I remember even when I was still nursing, and then Tannie Mari het 'n Facebook groepie wat sê, don't do.
Oh, but there's so much information out there, and I think it must be so confusing
and overwhelming.
And ChatGPT and Google, and but you know, it depends on what question you put in. If you're going to put in the question, is chemotherapy bad for me? You're going to get the negative ones.
Definitely.
If you're going to put in the question, what's the benefit of chemotherapy? in breast cancer, you're going to get the positive answer. So it's how you pose your question, and I think that's also about the outlook on life and the outlook on the treatment. So a patient's outlook and a patient's motivation to go through treatment is key to getting through it. Yeah. But our patients are amazing. They just are amazing, and their endurance and their chutzpah. I'm always so proud of them.
Now, also the big swear word is hormones. And HRTs. Oh, shamefully, Anne. I think yeah. Can you ever go to the shops, like to Woolies, and not have to explain yourself?
Never. And the cutoff is 8 years. You live in a place for 8 years,
And dan moet jy gaan.
and then you need to move. Okay, so I'm at 8 years now.
No, you can't leave George.
No, I'm not moving because my child's happy at school, but 8 years. Okay, so we generally, my husband and I have a joke, we count how many patients I bump into and how many people come and talk to me. But bless them. I don't always remember their names, but I can tell you what their disease is and I can tell you what treatment they had. Okay. So, hormones. So remember, once again,
please explain to everyone what is a hormone and that we do need hormones.
Oh, we do need hormones.
It's not a swear word.
Yeah, speak to me. I'm going through menopause. It's not fun.
Exactly.
Okay, so the female hormones are estrogen and progesterone or progestin. And by the way, we also have a bit of testosterone. Okay, that's the feel happy hormone that also gives us our sex drive. So the next time you're not in the mood, you just tell your husband you're low on testosterone. So we need hormones, and their primary reason we have them is for our reproductive health. I mean, that's why we have them. They're supposed to regulate our menses, our menstrual cycle, keep us fertile, but they do many other things. So we'll notice, I'll notice a decline in certain things when we go through menopause, our mental clarity, our energy. The aging process happens when we don't have these hormones. Okay, weight gain. Not having estrogen is associated with an increased risk, obviously, of osteoporosis, of cardiac disease. So hormone replacement therapy isn't a swear word. It just has to be done responsibly, okay? And it mustn't just be prescribed ongoing without being monitored.
Exactly.
Right. So patients who do not have a significant family risk of breast cancer, who are on hormone replacement therapy, just need to make sure that they do have their mammogram every year. Because just think of it this way. You're on hormone replacement therapy. You've been through menopause. You're on hormone replacement therapy. You develop a breast cancer, which is sensitive to estrogen. You're feeding it. You are giving it fertilizer.
Exactly.
So you will have a patient who has had a mammogram 2 years ago or 3 years ago. They've been on HRT. By the time they come to us, they've got these 5-centimeter tumors. And they go, they can't understand. They had a mammogram a few years ago. I'm like, because you're on hormone replacement therapy. You need to go for your mammogram every year.
Okay.
Because you're feeding it.
You're feeding it, but it isn't necessarily
the cause of it.
No. That's the big thing.
There's a very, very small increased risk with HRT. But it's not necessarily the underlying cause. It's just that you are fertilizing your cancer. If it's an estrogen receptor positive cancer, which in older patients or postmenopausal patients generally have estrogen receptor positive cancers, you'll be feeding it. So just think of it like fertilizing your garden.
Exactly.
Yeah.
But we don't need to suffer through menopause.
No.
There's amazing medications out there. You can take it.
So if one looks at guidelines, we shouldn't take it beyond 65. Okay. If one looks at guidelines, we shouldn't take it beyond 65. We should take it.
Why not?
Because of increased risks.
Okay.
Okay. So but it needs to be individualized.
Mm.
Okay, so you need to speak with your gynecologist, and they need to look at what your risk factors are. So you take it to mitigate the menopausal symptoms, the hot flushes, the mood swings, all the bad things that come with perimenopause and menopause. Patients who have osteoporosis can use HRT as a treatment for it, but there are other ways of treating osteoporosis. Patients who have family histories of dementia and cardiac disease, HRT is good for that. So it's not the swear word everyone thinks it is. However, once again, I'm an oncologist. I stop everyone's HRT because they come to me with breast cancer.
Exactly. Yeah.
Once you've had breast cancer, you cannot have HRT.
Wow, that makes sense.
If you've got a BRCA mutation, you cannot have HRT, except vaginal estrogens.
Okay.
Vagifem,
Yes.
which is 10 micrograms of estradiol, is a very low dose, and that can be used. Okay, it's minimal absorption, so vaginal estrogens are safe.
Safe for when
you've had breast cancer,
okay,
or BRCA mutation. It's the root where it is. It's a local estrogen.
So
for vaginal health, it's not absorbed. It's not systemic.
Okay, so it's not going to treat your other symptoms like the brain fog.
No, just your vaginal health.
Okay, so
So it'll prevent recurrent urinary tract infections.
Okay,
improve the vaginal dryness. Are we allowed to say that?
Yes, yeah. Okay, no, so it's a local. It works locally.
The absorption is minimal.
Okay,
but that's Vagifem, not the higher doses.
Okay,
they're different preparations.
Okay,
but the patients struggle with that. So even patients who have had breast cancer who are on the endocrine treatment that we give them, which is the anti-estrogen treatment, we can give them Vagifem.
Oh, shame.
No, they struggle.
Do they need to then be on that for life, or is it only for the treatment period?
So if it's as a preventative treatment, it will be anything from 7 to 10 years, depending on the type of treatment we give them.
Okay.
Yeah. It's a long time. It's probably the worst part of my job, is keeping patients on those tablets.
Yeah,
because they have hot flashes, they feel tired, they have the aging side effects, the low libido. Yeah. So it's worse than giving chemotherapy.
Really?
Yeah. Because patients got to take a tablet every day that makes them feel older. And they don't come and see me being happy.
Dr. Leanne, then when is a patient in remission? What does remission mean?
So remission means there's no evidence of cancer on scans or on bloods.
For now or in a period?
Those definitions are so difficult.
I know.
So, because typically, if a patient's had surgery and their cancer is removed, they're in remission. And then we give treatment to prevent cancer from coming back.
Okay.
Right. So that would be remission. Then there's a definition of cure. When is a patient cured? So we would say if you've been cancer-free for 10 years, we'd consider you cured. But there's still a risk that the cancer can come back, so we don't send you away and not follow up on you. Yeah.
So when a patient says, I'm in remission,
it means there's no evidence of cancer at the moment.
The difficult thing, we've touched
like the last
hour is not being difficult. The ethic part and the tough decision when the doctor advises treatment and when patients want to seek other alternatives or natural alternatives.
Patients have a choice. Each person, you are the captain of the ship, which is you. And they come to me for an opinion. I give them an opinion based on evidence-based medicine of what I can offer them. It's their choice as to whether or not they take that opinion. Obviously, it's very difficult for me when patients decline a treatment and I know they really need it, but I can't force people to do things. I generally have quite an open mind when it comes to some of the alternative or complementary treatments that patients want to use. So instead of doing an all or nothing, I would say, let's see what we can combine. So there's certain holistic practitioners that I will work with or do work with, and patients will see them, and often we can work together. And that's really important because I'm focusing on the disease, and often the holistic practitioner is focusing on health. And between the two of us, we can
Actually have a amazing plan.
Exactly. So it doesn't have to be an all or nothing. If patients decide they don't want to take anything of what I can do, it's got to be an open door if they change their mind. And we have that all the time. Generally, patients do come back, but they're on a journey, and they've got to prove to themselves the things that they feel they want to experience. So if they want to see if the latest is ivermectin or infusional vitamins or whatever it is going to cure their cancer, if they want to do that journey, they're welcome to do that. They will probably be back, and the cancer may be more advanced, and then we'll pick it up there. There's no judgment. There's no judgment.
No.
Everyone's on a journey.
And I think a lot of decisions are made out of fear.
Of course. No one wants chemotherapy. No one wants to hear they have cancer.
Yeah.
And often it just takes another session of counseling and some time. Yeah.
And you've said earlier how the treatments and chemotherapy and everything has changed over the years, and that it's actually more bearable. Is that the word?
Bearable, but there's so much more hope. If I think about 20 years ago, the thing we were so excited about was Herceptin, trastuzumab, for HER2-positive cancer. That was like the thing. Right. It was using that to prevent cancer from coming back, and it literally changed HER2-positive cancers. It was a fight to get it funded for patients. And if one thinks about 20 years ago, it was about 400,000 Rand for the year of treatment. And that's like 20 years ago.
Sure.
A lot of money. We didn't get it for everyone. It was an absolute nightmare. Now it's available for HER2-positive cancers. It's available. It's probably about 100,000 Rand for that year. So with biosimilars, it's become available and more affordable. So the next thing that I'm really excited about and that I've seen huge differences for the patients is we have an entity of breast cancer called triple-negative breast cancers, which are cancers that are not sensitive to estrogen or progesterone or HER2. They're typically really aggressive cancers. We see them often in the genetic carriers, so the BRCA patients. And the new thing with that is immunotherapy, where we add immunotherapy to the breast cancer, and that increases the complete response. So when you give the chemotherapy and the immunotherapy before the surgery, when you then do surgery, you don't find any active cancer cells. But the cost of this is exorbitant. That's a good 85,000 Rand a dose every 3 weeks. Sure. So that's our next fight. Okay. And we're managing to get it for some patients. Some patients self-fund. So it's going to be amazing when that becomes available to every patient.
Yes.
And I always say I'm an oncologist and a financial planner, because you've got to look at what budget's available, what are the medical aids going to pay, what can the patient afford, what rare disease policies do they have that we can use, and then work out a plan for a patient. So there's so many things one has to look at when you're working out a plan for a patient. So that's sort of the next exciting thing. Well, of course, there are lots of things in the pipeline, but that's what's available now. And
the next big thing.
The big thing it's already a big thing. It's now getting access.
Okay, wonderful.
It's getting access, yeah.
And it's amazing, and I think that is what also is all these amazingly intelligent people that works
advances medicine.
And that we can see improvement. One thing that when I just moved to George 11 years ago, I worked a bit with a surgeon. He's retired now, And I asked him, why does it feel that every second person has cancer? Is it because, and then he told me, but you must tell me if you feel the same or think the same as, he told me because it's so more advanced now and we can detect it earlier. And so it's not a bad thing. Or what do you think?
No, so the incidence of cancer is increasing, definitely.
Is it?
We're also seeing it in younger patients. So particularly in breast cancer, the incidence of breast cancer in females under the age of 40 is increasing. There was actually a publication in the South African Journal of Oncology just in May this year where they looked at a population in one of the Johannesburg state hospitals from 2012 to now. And they looked at the age of patients, and there's definitely an increase in the number of young patients that are being diagnosed. Yeah. So that's lifestyle. We are having our children later. We're all career women. I don't know about you, but I had my one and only child at 38.
Yeah, I started at 32.
Yeah, 38. We breastfeed for shorter because we've got to go back to work. We're exposed to, the number of hormones we're exposed to in our food.
So that does play a role.
Play a role. We're on oral contraceptives from a young age. I mean, how many girls are put onto oral contraceptives in school years to regulate their menses? So we're exposed to these exogenous hormones for decades. For decades we're exposed to it. And that's increasing our...
And stress.
Lifestyle.
Lifestyle.
All the things I said in the beginning. The alcohol, we don't exercise, we're not eating healthily, we...
Smoking, vaping. What is your take on vaping? I think that is a big question. I stopped. 12 months.
Well done. Well done. It's not good for you.
Oh, no. No, I know. I'm so glad I stopped. So it's not.
We all have vices. We all have vices. None of us are perfect.
Exactly.
I don't exercise enough. I carry a bit extra weight. None of us are perfect.
But it's not. Because a lot of people think that dis is erg soos rook nie.
It's baie sleg vir jou.
Yeah,
just don't do it.
No,
don't do it.
And it's so much more addictive. I think.
Oh yeah.
I did smoke cigarettes way back. On and off. Then I will stop for a few years, and because my husband never smoked. And that was the one thing my dad told me before I went to varsity. He told me, listen, rook is lekker. Moenie begin rook nie. Obviously I didn't listen to him. And then...
so have you swapped it for wine now?
Now see. Now
Three a week.
3 a week.
3 a week. I've just spoiled that one for you.
No, exactly. Yeah. So I've stopped the vaping and smoking. I'm taking the alcohol up. But, okay, stop vaping. And do you find that because there's more cancer, it's earlier, is it hopefully patients that they themselves, that's actually they're not too late, but they felt it themselves?
The younger patients, it's a difficult one because they're not having mammograms.
No.
So they're usually self-detected lumps. Their mammograms are inaccurate because they have dense breasts. They reported as benign lumps or it's not visible. So they are generally more advanced. They can be more aggressive tumors. They generally need chemotherapy. And obviously there's a whole quagmire of things we have to navigate there because we have to navigate their fertility, whether they're wanting further children, the chemotherapy, the genetic testing. It's just when you're treating a 32-year-old or a 27-year-old with breast cancer, it is a much bigger parcel to take on. Yeah.
Okay, so for the 40 and younger that don't go for mammograms, we should self-examine.
Self-examination. Yeah, self-examination is still important there. because it's not a screening tool, because by the time you feel a lump, obviously it's an issue. You're not going to ignore a lump. If you do see a doctor and there's a lump and they say, and it's been diagnosed as benign, so you've had an ultrasound, they've had an x-ray, they say it's benign, but you notice in a month or two that this thing is growing, the lump is growing, don't leave it at that, because there can be misdiagnosis. Remember, none of us are perfect. There can be misdiagnosis. You go back to the doctor, you say this lump is growing, it needs a biopsy. Okay. Yeah, because there can be errors. Remember, no test is 100% other than a biopsy. And a mammogram's not 100% accurate. It just is a suggestion of a benign lump. So if a benign lump shouldn't grow rapidly. Okay. All right. So don't just leave it.
So self-examination is still, and then also if you know that you have family history, you must just be more
vigilant, more vigilant. And, obviously with the family history, if there is something that needs a genetic test, I think that needs to be looked into with a genetic counselor. There are only genetic counselors in Cape Town, or, they're not in George.
Okay.
So the group we use are in Cape Town. Obviously, they're groups in Johannesburg as well. They typically do Zoom meetings with the families and then assist in sorting out the counselling and testing. Okay. There are only about, I think, 30 of them in the country. So, yeah.
Okay. Dr. Leanne, I remember with the nursing, baie lank terug. Okay, so we examine our breast. If we do it, you do it monthly and around the same time.
Yes, in the middle of the month, so not around your period, 2 weeks after.
Okay, in the middle of your cycle.
Middle of your cycle.
Okay.
Yes.
And with the self-examination, you take your palm of your hand. You don't take your fingertips.
Yes.
The palm of your hand and massage from the outside
all the way around the breast. And you should do it in 2 positions, actually. So you can do it in the shower, but then also when you're lying down, because the breast tissue moves and you may miss an area of the breast.
Okay.
Only doing it in the shower.
Standing with your arm.
Standing up.
Okay.
And make sure to feel under the arm as well, because your breast tissue extends all the way up into your axilla or armpit. So you want to examine up there as well. Yeah.
And then when you do your self-examination, the reason why we don't use our fingertips is because you're not going to feel the difference in the tissue area. If there is a lump, you will feel the difference.
Yeah.
Jy voel fynner met jou vingerpunte, gaan jy eerder ietsie voel, and then it's not necessarily something. It's just dense tissue.
It's a difficult one. I would use usually palm and both. And also if you know your breasts, you're going to notice a difference. It's about knowing what your breasts feel like and noticing a difference from 1 month to the next. But obviously the things that you're not going to ignore is if you have your nipple changes, your nipple pulls in, you have a change in the skin color or texture of your breast, or you have a nipple discharge, or obviously a lump. That's an obvious one. Or if your breasts change size, that can be one of the only signs of a breast cancer. For instance, a lobular cancer, the breast could change size. The one breast could become smaller. So don't ignore breast asymmetry either. So those would be the signs that I would definitely.
And a lump will typically feel, you will
hard, painless, usually.
Okay.
So painful lump is usually more.
But it will be a definite knoppie.
Yeah.
So it's not just a
rubbery,
squishy
thing. No.
Definite lump. And then,
and if you're concerned, you go to your GP and let them examine. No, don't ignore it.
Okay, so on a monthly basis, in the middle of your cycle, also a tip that I've read somewhere.
No, it's the same with a mammogram. You should try and time it in the middle of your cycle.
When you book your mammogram, okay.
It's difficult to do because you're sort of booking it months in advance, but it should be in the middle of your cycle.
And monthly so that you can feel the difference from the previous month until now. If you do it on a daily basis, you're not going to feel necessarily if there's a difference.
We should just at least do it monthly.
Yeah.
We're quite bad at that, though.
I know.
Because we're too busy.
Yeah. It's 30 seconds that you can actually,
It takes you longer than 30 seconds.
Yeah.
6 minutes is usually roundabout, yeah.
Okay, so that's how long.
It's how long it should take to examine your breast properly.
Okay, yeah, that's also an important point. And then a tip that I got, also, I read it somewhere, I can't even remember where it was, is that, and I've done it for years now, is to book my pap smears in the month of my birthday so that you can remember it.
You do that?
No, exactly. Happy birthday. Happy birthday. No, just to remember, and then not let the year pass again and you haven't went for your checkup.
Typically, I book my mammogram for Valentine's Day. It's never busy on Valentine's Day. No one else wants to go for a mammogram on Valentine's Day.
But yeah, so because that is also it's such
You
a
forget.
You forget, and then a year has gone by, or 2 or 3, and then everyone's gaan more ballak.
And you need at least 3-4 months before you can get an appointment for a mammogram. You probably need 5-6 months before you're going to get an appointment with your gynae.
Exactly. So just book it in advance.
Exactly, and then put it in a note on your phone.
Definitely. And
what a reminder.
Yes. With the survivorship, what does it look like after treatment?
There are 2 very stressful times for a patient. One, when they're diagnosed, and second, when they stop treatment, because then it's what now? What now? So that survivorship and follow-up schedule needs to be really clear to them. They need to know what's going to happen now. For some patients, they're going to be on an anti-estrogen or an endocrine treatment medication. There will be doctor's follow-ups. In the first 2 years, it's usually every 4 months. They'll have blood tests with every visit. They'll have x-rays and a mammogram or a breast MRI once a year. After 2 years, we'll normally extend that to maybe every 6 months. And then you can see now, okay, the risk of it recurring is less. And by 5 years, we'll say, okay, we can now see you once a year. So that risk of it recurring is highest in the first 2 years, which is why we're going to see you sort of every 4 months. And then it's about finding your new normal, because patients are not quite the same. After that experience, you've either got side effects from the treatment, or it's a complete life-changing event. You see ththings differently. You've got a different perspective on life. You'll often hear of women who change careers because they just realize, well, life's too short to do what they were doing, or they find new meaning in life. And that's not always a bad thing. They find a new passion. So, yes, and there are scars. And they need to, or they often learn to embrace those.
What message do you want women to take, especially now in Breast Cancer Month? What is something that you think every woman should know about breast cancer?
So I think it's more than just breast cancer. We focus a lot on breast cancer. I think the most important thing is that you're actually responsible for your own health, not your general practitioner. Your GP is going to deal with your disease when you see them, but you are responsible for your health. You are responsible to make sure you go for screening. We all have had things in the past. We can't change our past, but we can change our future. We can change how our future is going to look. We can eat healthily. We can try and exercise. We can cut back on the negative habits and decrease our risks. Those are the things we can do. We can't change our genetics. So I really want each woman to look at her life and see what can she do better. What can she do better? Not in a negative, critical way.
No.
What can we do better? And what are we doing in our lives that are are not positive for our health, and are we taking stock of everything? And it's not just about breast cancer, but all cancers.
Yeah, taking ownership.
Take ownership. You, as I keep saying, you're the captain of the ship. No one else is going to do it for you.
Breast cancer in men.
Okay, so breast cancer can happen in men. It's generally associated with the BRCA1 and 2 mutation families. So if there's a family history of a male in the family that's had breast cancer, that's a sure sign that there is a BRCA mutation in the family.
Okay.
Male breast cancers, they used to say, make up about 1% of breast cancers. I would say it's probably lower than that. If I look at the number of patients in my practice, I'm not seeing one male for every 99 females, but maybe that's just my practice. But the statistics were always that 1% of breast cancers happen in men. So men also have breast tissue.
Yes.
And they would have the same treatment that a woman would have for their breast cancer, dependent on the personality of the tumor.
And obviously it's not an estrogen.
Yes.
Oh, really?
Yes. They can have estrogen-driven tumors. Yes.
Oh.
Yes. Remember, it's derived from the breast cell. Breast cells have estrogen and progesterone receptors. The reason why men don't grow breasts like you and me, because they don't have estrogen and progesterone to drive that during puberty, but they still have estrogen and progesterone receptors on the breast cells.
Receptors is nog daar.
Yeah. So the tumors can still be estrogen and progesterone receptor positive. So we still use the anti-estrogen treatment in them.
So if a male has breast cancer,
Yeah.
it is definitely because there was breast cancer in the family.
Well, he can be the first male. So remember, the mutation has to start somewhere.
Dan moet die eerste wees.
Oh, the ERC. So it could have started, but that family needs to be tested. So he needs to get a BRCA test, because then there's a family. He'll probably have children. He'll probably have children. So we test him to then test the rest.
Okay.
So you don't ignore that from a genetic perspective.
Ek hoor, ja.
Yeah.
Okay, but and in a male's case, that would be, I assume he would have felt it.
A lump, because he's not going to have
Ek gaan nie, nee.
So men with a lump, and it's usually around the nipple that they, or under the nipple that they have a lump. And often they present late because men don't think anything. So it's often growing into the skin. They also have a mastectomy, by the way. They also remove the entire breast tissue, the nipple, because you can't do breast conserving surgery. They also have a mastectomy. They usually remove both. But yeah, they do a mastectomy, we do BRCA testing, and they'll do the same path as we have for a female.
And in your career, have you had males? Oh, you did?
Yes.
Okay, but that is, and it's not necessarily that can be the first cancer. It's not because they had maybe the
Cancer somewhere else.
and
No,
now
it's not metastasized. So it's not a cancer from somewhere else that's spread to the breast. It's a cancer that started in that breast tissue behind the nipple.
maar in 'n male.
En 'n man.
So hulle sins al kon ook begin, number 1, the first cancer was the breast cancer.
Yes. Because they also have breast tissue.
Just as eintlik, ja. And I obviously feel sorry for them because they only felt it late on. Also, when it's cancer. That is also interesting. So that's also something. And I assume also in obese patients and so that they do get fat.
So then they maybe won't feel it. So being obese isn't going to make their risk any higher, other than whether it's a lifestyle factor. But usually in men, it is going to be a genetic thing.
Okay.
Yeah, it's going to be more a genetic thing.
Dr. Leanne, ek het al so baie gewonder. How do you cope? Met 'n pilletjie. Because you deal with this every single day, and for the most part, I would think as a person on the outside that it's a heavy.
Heavy.
Yeah.
It's heavy. So sometimes I don't feel like I'm coping.
Mm.
How do I cope? I think you should ask my colleagues. So I try really hard to not take it personally, but that's not in my personality.
Mm.
I'm a very sensitive person, so I feel failure when my patients don't do well.
Mm.
I suppose I have to believe that I'm not in charge of life and death. And I think that's what's helped me through my 20 years in private practice. The Lord has set a path in front of us. I'm here to help patients. I didn't cause the cancer.
Mm.
I can do as much as I can to ease suffering and prevent relapse. That's important. But coping, I immerse myself in my family when I'm not at work. Yeah, there's a lot more I could do, but we'll get there.
Shame you're now. You are. We had a struggle just getting a date for this because you're so busy, and then you have your husband and your son.
Sent them away for the weekend.
But there's also a time for yourself to have a breather. But I'm glad that you do have your moments and that you can cope, because you are really a strong woman, and you've dedicated so much in general to the whole of the garden route. I have several clients that are patients of yours, and they speak highly of you.
Well, I'm only one person in an amazing team.
Yeah.
So our practice is I'm one of 3 oncologists. We work as a team. So we're always discussing patients. You know, I don't know what to do with this patient. You don't know what to, and you can't work alone. You can't, because you can't know it all. And you have to get opinions from colleagues. You have to work as a team. And I think, I was talking about what excites me as in treatment, but what's excited me even more for the garden route is our multidisciplinary teams. And I don't think I've mentioned that. We have that in George and in Mossel Bay. So in George, if you have a mammogram, a garden route radiology, and there's an abnormality on that mammogram, and you've had a biopsy that's proven a cancer, your case will be discussed at a multidisciplinary team meeting. We have a monthly meeting. So 4 doctors or 4 specialist groups will be at a meet down and will discuss your case, and we will make sure you will not slip through the gaps, because the worst is when a patient has a mammogram and a biopsy and no one follows up. So there's that safety net. And it's just amazing that we've managed to put that together. Mossel Bay as well. So
that's amazing.
Yeah.
Tell me, Dr. Leanne, the thing that I didn't ask you now when you spoke about the private sector, does public sector get the same treatment as private?
Okay, so our public sector in George has a really great oncology unit.
Okay.
Their treatments, they have an excellent chemotherapy protocols. They have radiotherapy protocols. They have a very good surgical team. The only thing that they don't necessarily always have access to are some of the newer drugs. Okay, it's like the trastuzumab, and obviously not the immunotherapy, which even patients in private don't always have access to. The state sector, however, does not have a screening program. So mammograms are not available for screening in the state sector. So patients would only get a mammogram if there is an abnormality that they are concerned about.
Dr. Leanne, thank you very much. I think you've mentioned all the important things, and we should take ownership. And there's hope.
There's hope. There's lots of hope. There's lots of hope. There's great treatments. We have amazing survivors. And I just keep saying, I'm so proud of my patients who face all the challenges. They're the heroes.
Definitely.
They're the heroes. Come back every week, every 2 weeks for their treatments. Sometimes not with a smile, but they come back. Yeah.
Now, I do look up to those patients, and it's amazing that we are this far, and that we have you, your team, in the garden, Ruth.
Thank you.
And thank you again for everything that you do.